tools that have been revisited to accelerate weaning. So those are my conflicts of interest. So, as previously shown in this session by the WinSafe study, only 65% of patients achieve weaning success 90 days after the intubation. So we as physicians are looking for tools to accelerate weaning and to reduce the percentage of patients who failed weaning. So we can consider weaning failure as a load capacity imbalance, which means an imbalance between the load, the respiratory system mechanics, resistance and compliance, and the capacity of respiratory muscles to cope with this load. So, of course, if we want to hasten weaning, we can try to reduce respiratory system mechanics. Like, for instance, treating lung disease, weaning-induced pulmonary edema. I'm not going to talk about that this morning. But we could also help respiratory muscle to cope with respiratory muscle loading. And we have 3 different tools on which there's ongoing research with published results, and tools you're going to hear about during the next few years, which are techniques to increase the strength of respiratory muscles. So let's consider 3 different situations. Like the first one is my patient is intubated, does or does not trigger the ventilator. And the second situation is my patient is intubated, but can definitely sustain pressure support ventilation. And the third one is my patient is intubated or often tracheostomized actually, and can fully participate to rehabilitation. So, for my first patient intubated, does or does not trigger the ventilator, there's ongoing research on diaphragm neurostimulation. What's that? So, in someone who is breathing naturally, inspiration is driven by the contraction of the inspiratory muscles, and the diaphragm is the main inspiratory muscles. So those muscles contract, and they create a negative pressure inside the thorax, which creates a gradient of pressure between the mouth and the alveoli, and this airflow results in inspiration. If my patient is placed under a ventilator and is fully sedated and relaxed, then inspiration is driven by the inflation delivered by the ventilator. So, neurostimulation, diaphragm neurostimulation, consists in stimulating the phrenic nerve of this patient under mechanical ventilation. So, diaphragm neurostimulation will superimpose some natural inspiration driven by the artificial contraction of the diaphragm, which is paced by the stimulation of the phrenic nerve. And this will be superimposed to inflation delivered by the ventilator. Until recently, the techniques for phrenic nerve stimulation were mostly very invasive, and it was mostly for patients with central respiratory paralysis, for instance, tetraplegic patients with a full paralysis of inspiration. but more recently have been developed less invasive techniques that allow a temporary stimulation on the phrenic nerves. One of them, but there are other ones, but this one is the one that has been most studied to date, which is a catheter that is inserted in the subclavian vein, and this catheter is equipped, you see, with electrodes that are placed in front of the phrenic nerve, and that will stimulate the phrenic nerve. And in an animal model of phrenic nerve stimulation using such catheter, you can see here two different types of cycle. Here is the transdiaphragmatic pressure here, which is produced by diaphragm contraction. And you can see two different types of cycles. Here we have a normal cycle here where there is no diaphragm contraction. And here we have a paced cycle in which there's a contraction of the diaphragm that is induced by the phrenic nerve stimulation by the catheter. So you see two different morphologies of pressure. So in animals, what have been shown is that this phrenic pacing can partly prevent the ventilatory-induced diaphragm atrophy. So we have here an example of an animal. On the left, we have the control group, no mechanical ventilation, no phrenic pacing. And as compared to this group, in the middle, we have a group of animals with mechanical ventilation, no pacing, and you see clearly that the cross-sectional areas of diaphragm fibers is reduced. And when we add phrenic pacing, we can see that this atrophy is partly prevented. Not fully, but partly. More recently, there was a multi-center trial in which 110 difficult-to-wean patients were included, and in which Samir, actually, your group participated. And the primary outcome was successful weaning from mechanical ventilation. And you can see that there was, unfortunately, no difference between the patients in which the control group, and the patient treated by phrenic nerve neurostimulation. However, in patients who received phrenic pacing, you can see that there was a significant improvement in the maximum inspiratory pressure. Very recently, the Yuan Golliger's group from Toronto innovated a kind of new concept, which is on-demand stimulation of the phrenic nerve. So the concept is to deliver no stimulation when respiratory drive is present, and when there is no respiratory drive, then the stimulator delivers stimulation to achieve a moderate level of diaphragm contraction. And on this pilot study recently published in the Blue Journal, you can see that this on-demand stimulation technique was able to achieve stimulation when it was necessary and not achieve stimulation when it was not necessary. So in addition to this phrenic pacing, you could also add abdominal muscle stimulation. Because as we said previously in this session, diaphragm is important to separate patient from the ventilator, but abdominal muscles are essential to cough. And cough is essential to guarantee extubation success. And there is now techniques to stimulate abdominal muscles. So the principle is to place electrodes over the skin, and these electrodes are piloted by a tool that is connected to ventilator circuits and that synchronizes the abdominal stimulation with the flow delivered by the ventilator. And the results of two recent pilot studies in which difficult-to-wean patients receive stimulation session 5 days a week, twice per day for 10 minutes. Sorry, no difficult-to-wean patient, actually, mechanically ventilated patients. The compliance was 90%, and you see here that in the group of patients who receive abdominal stimulation, the abdominal expiratory muscle thickness increased as compared to the sham group. And in addition, you can see that there was, in the patient who received abdominal muscle stimulation, a trend toward a shorter time to extubation and a shorter time to discharge from the ICU. If my patient can sustain ventilation, can sustain pressure support ventilation, then I can use a proportional mode of ventilation, like NAVA or PAV. What's that? Here is the level of assistance of the way axis that delivers a ventilator as a function x-axis of the patient's inspiratory efforts. With pressure support ventilation, you can see that the level of assistance that is delivered by the ventilator is constant, irrespective of the intensity of the inspiratory effort of the patients. The problem, so, is that sometimes, if the patient makes a low effort, the patient receives too much assistance. But sometimes, if the patient makes a huge effort, assistance is probably too low. The concept of proportional modes is to deliver a level of assistance that is proportional to the intensity of the inspiratory effort of the patient. If my patient makes a low inspiratory effort, my patient received a low level of assistance. If my patient makes a huge effort, it means that my patient needs more assistance and receives more assistance. One of these modes in neurally adjusted ventilatory assist, in which the level of assistance delivered by the ventilator is depends on the intensity of diaphragmatic electrical activity that is captured by electrodes placed in the esophagus in front of the diaphragm. And there's recent interesting data in a cohort of 99 difficult-to-wean patients who were randomized to receive either pressure support or NAVA. Those were patients intubated for more than 48 hours with weaning failure, no vasopressors, and able to sustain PSV. And those patients were randomized, and what you can see is that patients who received NAVA were successfully weaned from mechanical ventilation earlier than those who received pressure support ventilation. There is also an ongoing trial there's also an ongoing trial using another mode of proportional ventilation, which is PAV, proportional assist ventilation. Then, if my patient can fully participate, then I could use inspiratory muscle training. So, inspiratory muscle training is like pumping iron, but for the diaphragm. And this is mostly for prolonged weaning and mostly for tracheostomized patients. So it consists in making sessions of training, of inspiratory training against a resistance or an elastic valve. There has been to date a couple of studies on this, and this seems to be a promising technique. This is probably one of, I would say, the studies that has one of the best design. In this study, all patients tracheostomized had 4 sets of training per day, 5 days a week. 69 patients were randomized, and you can see here that the proportion of patients weaned from the ventilator was much higher and significantly higher in the group who received training as opposed to the sham group. The meta-analysis on the subject show that there's definitely inspiratory muscle training improve respiratory muscle force generating capacity. But regarding clinical outcome, more studies are needed, and one is ongoing, and we expect to get the results very soon. So, in conclusion, regarding those new and old tools to accelerate weaning, phrenic nerve and abdominal muscle stimulation, we have promising human data and studies are going on. We could promote diaphragm contractile activity using proportional modes. There are positive data with NAVA, ongoing study with PAV, so probably very interesting results very soon. And regarding inspiratory muscle training, there's a reasonable, interesting amount of data showing that it probably has a role, but mostly in fully awake tracheostomized patients. Thank you very much for your attention.
So thank you very much. I realize the session is just running over. We have time for one quick question, if anybody has a burning question in the audience. Yes, please.
Thanks for this great session. I'm Younes from Morocco. My question is maybe for all the speakers. What about tracheostomy? Is there any new guidance, new data? When and for whom? Thank you.
That would be a whole session, a whole session with
so much for the
6 talks. No, there is not that much new data. What we know is that we should not wait too much when we know that the patient will need tracheostomy, but there is not that much new data. But that would be a whole session.